Today, we're beginning a comprehensive look at the respiratory system, which at its core serves one essential physiologic purpose: oxygen delivery and carbon dioxide removal. While that sounds simple, achieving this requires exquisite structural specialization, precise control mechanisms, and tight integration with the cardiovascular and nervous systems. Throughout this lecture, I want you to think beyond memorizing anatomy and physiology and instead ask, how does structure optimize gas exchange? And how does dysfunction at any point affect the whole system? We'll build from an upper airway anatomy perspective all the way down to alveolar gas exchange and regulatory control. These review questions outline the intellectual roadmap for this lecture. By the end, you should be able to move fluidly between anatomy, histology, and physiology. For example, explaining how epithelial type predicts function or why certain cartilages are elastic versus hyaline. These questions are not meant to be memorized verbatim. They reflect the conceptual expectations you should be able to reason through clinically and physiologically. The respiratory system exists to support cellular respiration. Without oxygen delivery, oxidative phosphorylation halts within minutes. To meet this demand, the system performs four integrated functions: ventilation, diffusion, transport, and regulation of ventilation pH. Importantly, none of these occur in isolation. Gas exchange is meaningless without circulation, and ventilation without regulation rapidly leads to acid-base derangements. This is why respiratory physiology is inseparable from the cardiovascular system and the renal system. Respiration is not synonymous with breathing. Breathing or pulmonary ventilation is only the first step. External respiration refers to gas exchange at the alveolar capillary interface, while internal respiration occurs at the tissue level. Transport of gases depends on hemoglobin affinity, cardiac output, and vascular distribution. Finally, cellular respiration refers to the mitochondrial oxygen utilization. Clinically, pathology can occur at any of these levels, so any of these listed here. For example, anemia disrupts transport despite having normal ventilation. Beyond gas exchange, the respiratory system contributes to olfaction and speech. These are functions that require specialized epithelial surfaces and precise neuromuscular control mechanisms. These quote unquote secondary roles explain why respiratory disease often presents with symptoms like anosmia or voice changes before oxygenation is noticeably impaired. This highlights the system's multifunctional design. We divide the respiratory system into upper and lower components for organizational clarity, but physiologically it functions as a continuous conduit. The upper respiratory system primarily conditions incoming air by warming, humidifying, and filtering it, while the lower system focuses on air conduction and gas exchange. This division also explains why epithelial types and structural support change as you move distally. This table looks at the major upper respiratory systems and structures as well as their functions. Pay close attention to how mucosa type reflects mechanical stress. For example, stratified squamous epithelium, where abrasion risk is higher, versus pseudostratified ciliated epithelium, where particle clearance is more crucial. This concept will reappear repeatedly as we move deeper into the airway. This is where histology really ties in with physiology. We'll stop here. When we come back, we're going to look further at our upper respiratory system, the nose and paranasal sinuses.